Now we move into embryology and fetology. I want to look with embryology at week 1, 2, 3, and then 4 to 8. And it's important to note this is post-conception week. Now, obstetricians and physicians generally talk about the weeks of pregnancy using the term menstrual weeks. And we start the pregnancy with the beginning of the last menstrual period. Now, you realize, of course, in a 28-day cycle for the first 2 weeks, there is no pregnancy even there. So really, technically, the embryologists are more precise where they start dating the pregnancy from conception. So we're going to look at post-conception weeks rather than menstrual weeks. But remember, you can easily convert conceptional weeks to menstrual weeks by adding 2 weeks. So this would be menstrual week 3, menstrual week 4, and so on. We'll look at week 1, week 2, and week 3. Week 1 starts with ovulation and ends with implantation. We start with the egg. And here we have the zona pellucida. Here we have the corona radiata. The egg is released from the ovary, and the site where it was released forms the corpus luteum, which produces progesterone. Here we have a number of eggs under the microscope. These eggs are the largest cells next to the neural cells in a woman's body. Here we have huge numbers of sperm, which are bravely seeking to fertilize this huge cell, small cells with the large cells. And here you can see under a microscope as they're all trying to become the dominant sperm. Ultimately, only one is going to do it, in most cases. All right, we look at week 1 post-conception. And here we have ovulation, which is on a 28-day cycle where it usually occurs, day 14. We have fertilization, which occurs then within 12 to 24 hours of ovulation. We can divide the first week post-conception into 2 phases, the intratubal phase and the intrauterine phase. The intratubal phase is where we have the zygote. As it moves down the tube, it becomes a 2-cell, a 4-cell, an 8-cell, and so on. It is called, when it is a lump of cells, a morula. The morula enters the uterine cavity in the middle of that first week, and it develops a hollow core and becomes now what we call the blastocyst or blastula. So we have fertilization, the zygote which develops here, and we have the blastula which develops here. Now what is interesting, if we have twinning which occurs in the first half of the first week, it will be a dichorionic, diamniotic placentation. We'll talk about this later. If we have twinning which occurs after the blastula is already developed, it is a splitting of the inner cell mass, and now we will have a monochorionic, diamniotic placentation. So here we have the 1-cell stage, which becomes the 2-cell stage, which becomes the 4-cell stage. Okay, you've heard about stem cell research. This is the morula. And if you take one of those cells from the morula, each of those cells is totipotential, and you can do pre-implantation genetic diagnosis on one of these cells, and you will not interrupt the normal sequence of development. So here we have the blastocyst. It is a outer core of trophoblastic cells, and we have the inner cell mass, which is known as the embryoblast. This will then, at the end of the first week, implant onto the endometrial cavity. So here we have ovulation, which occurs. Fertilization typically occurs in the distal tube, and we have the 1 cell, the 2 cell, the 4 cell, and so on, and the morula enters into the uterine cavity and becomes the blastocyst. So in summary, the morula develops week 1, the blastocyst develops week 1. Okay, and so now we move to post-conception week 2. Post-conception week 2, if you can remember, 2 layers in the germ disc. Bi-2, formation of the bilaminar germ disc. And here we have the blastula as it is approaching the endometrial surface. Here we have the maternal sinusoids, which the trophoblast is going to be heading for. It wants to invade those. And this is what happens at the end of week 1. And here we have the implantation, which has occurred. And if you look carefully here, you can see the 2 layers, the hypoblast and the epiblast. And here is our trophoblast. This is the syncytial trophoblast and the cytotrophoblast. Here you can see a little bit better. The 2 layers, we have the epiblast, the hypoblast, we have the cytotrophoblast and the syncytial trophoblast, and the syncytial trophoblast is heading for the blood vessels. This is in the 2nd week. This is another picture from Gray's Anatomy, which shows the 2 layers. We have the hypoblast, the epiblast. Here we have the cytotrophoblast and the syncytial trophoblast as they are invading. So, in summary, the 2 germ layers develop week 2. And once the syncytial trophoblast invades into the maternal sinusoids, the beta-HCG, which is produced by the syncytial trophoblast, now becomes detectable in the maternal blood, week 2. All right, we move to week 3. Week 3 is the formation of the trilaminar germ disc. So bilaminar germ disc, week 2, trilaminar germ disc is week 3. And here we can see a cross-section of the early developing embryo. This is the epiblast, which will become the ectoderm. This will be the mesoderm. And this is the hypoblast, or which will become the endoderm. So we have the 3 layers which are forming here. Again, ectoderm, mesoderm, endoderm. This is a rat embryo, and you can see the ectoderm on the top, the endoderm on the bottom, and the mesoderm, which is in the middle. This is day 18 post-conception, which is the 3rd post-conceptional week. Again, the zygote, week 1. Blastocyst implants, week 2. The 3 germ layers forming, week 3. And this just shows the derivatives of each of the layers, the ectoderm, the mesoderm, and the endoderm, and this is all step 1 stuff. I don't think they're going to ask this on step 2. So the 3 germ layers develop on week 3. Week 4 to 8 is now set in motion for the formation of the major organ systems. And you cannot develop any of the organs until you have the 3 germ layers which have developed. So there is really no chance for teratogenesis unless you have the 3 germ layers. And that develops week 3. And so when we look at the major impact of teratogenesis, whether it be from medications or radiation or hyperthermia, it's going to be weeks 4 to 8. Now think of this. If these are post-conceptional weeks, in menstrual weeks, this is weeks 6 to 10. Now, when do most women present for their first prenatal visit? How many weeks gestation? It's not uncommon to see 8 to 10 weeks, menstrual weeks. By that time, the organ systems have already developed. There is probably little you're going to do to prevent any malformations by that time. So this is very early when these impacts will have their effect. Okay, embryology of the female reproductive tract. Our main concern is the Müllerian or the paramesonephric system. Here you can see the kidney over here, which is the derivate, or what the kidney will be derived from. And here we have the paramesonephric duct, which will become the Müllerian duct. And you can see there's two of these. This one is cut off, but you can see how close the kidney and the paramesonephric duct are. The impact of this is that if you have a malformation which occurs in the Müllerian system, be alert that you may very well have a malformation also of the kidney or of the urinary tract. So the Müllerian and the urinary tract develop very, very close to each other. This is showing the close relationship in the undifferentiated embryo of the Müllerian duct here and of the Wolffian duct. Now, the Müllerian duct will develop into the uterus in a female. The Wolffian duct will develop into the male internal reproductive organs. The Müllerian duct is initially double, and it fuses. And the fusion of the Müllerian duct produces the oviducts, the uterus, the cervix, and the proximal vagina. Here's another way of looking at it. The Müllerian duct fusion gives rise to the oviduct, the fimbria, to the corpus of the uterus, to the cervix of the uterus, and to the proximal vagina. So if we have a complete androgen insensitivity, or Rokitansky-Kuster-Hauser syndrome, where you have failure of the Müllerian duct to develop, what is missing? We will have the fallopian tubes missing, we will have the corpus of the uterus, the cervix, and the proximal vagina. Those are missing with Müllerian agenesis. The early anatomy of both the female and the male is identical, the external anatomy. And when you look to a very early embryo, you really couldn't tell whether it's a male or a female. The differentiation of the external genitalia is very much impacted by hormones, particularly in the male. In order for the male external genitalia, for the penis, for the scrotum to develop, you need to have androgens present. Is there any hormone which is needed for differentiation of external female genitalia? And the answer is no. In fact, you can have, with androgen insensitivity, a genetic male, but who develops female external genitalia, mainly because there are no receptors for androgens. All right, this is a kind of a busy slide, but I think it'll make it clear, and it's quite simple. We're looking at what hormones are needed for female genital development, what hormones are needed for male genital development. In terms of external genitalia, what hormones are needed to form the labia? And the answer? None. What hormone is necessary for proliferation and development of the Müllerian duct? None. What hormone is necessary for, in a female embryo, for the Wolffian duct to involute? And the answer is none. So the default differentiation in an embryo, unless there is something which determines it moves in another direction, the default differentiation is going to be in a female direction. What is necessary for external genitalia to form in the male? DHT, which is the most potent androgen, dihydrotestosterone. That is needed to form the external genitalia, the penis, and the scrotum. What is necessary for proliferation of the Wolffian duct internally? Androgens, testosterone is necessary. What is needed in order for the Müllerian duct to involute in the male embryo? Müllerian inhibitory factor, which is produced by the testes. So you can see that the default differentiation is female because there are no hormones which are needed. That's the way it will automatically go. In order for male genital development, DHT to form the external genitalia, androgens to proliferate the Wolffian duct, and Müllerian inhibitory factor for the Müllerian duct to atrophy. When you have complete androgen insensitivity, you will have failure of the Wolffian duct to develop because there are no receptors to the androgens. But the Müllerian system will involute because the testes still produce Müllerian inhibitory factor. This is in your notes, looking at the Wolffian duct. In the testes, we have the Sertoli and the Leydig cells. The Sertoli cells produce Müllerian inhibitory factor, which cause involution of the Müllerian development. And so you have no uterus, no ovaries, no cervix. The Leydig cells produced testosterone, and those will cause virilization of the external genitalia as well as maintain the Wolffian development. And so we have the development of the seminiferous tubules and the vas deferens. The testosterone is converted by a 5-alpha reductase enzyme into dihydrotestosterone, which is the most potent androgen, and those will bring about virilization of the external genitalia. Okay, let's now turn to teratology. And we're going to look at the definition, the stages, and the types of agents. A teratogenic agent is anything which disturbs normal development and affects subsequent function. This could be a drug. It could be a energy source, such as X-radiation, or it could be hyperthermia. What is interesting is that the effect of a teratogenic agent is very much time dependent. There are certain gestational ages where certain teratogens will have their impact. If you wait until after that, even a few days, it will have no effect at all. All right, we've already looked somewhat at the stages of teratogenesis. This just reviews what we've already said. What is the effect of a teratogen on the embryo by gestational age? From conception until the end of week 2, there is nothing. It will either survive intact or it will die. And the reason is because there are no germ layers. Because it's not until week 3 and further that you have the 3 germ layers. So prior to that, intact, survival, or if there is effect which is severe, the embryo will die. Post-conception, weeks 3 to 8. Now here's where we have the risk. And week 3 is really pretty minimal. You've got to have the 3 germ layers in order for there to be a possibility for teratogenesis, because that's the germ layers. 8 conceptional weeks or 10 menstrual weeks, all of the organs have formed. After week 8, we're going to have either hypertrophy or hyperplasia, and those are post-conception weeks 9 plus. And what is, I think, very fascinating is the resistance of this early fetus to external influences. Here we have a patient who is our case. 36-year-old woman underwent a barium enema for rectal bleeding on February 1 with an estimated radiation dose of 4 rads. Her last menstrual period was January 1. She has 35-day cycles. All right. She had her last period on January 1. If she had her last period on January 1, if she had 28-day cycles, when would she ovulate? She would ovulate on day 14. If she has 35-day cycles, what day did she ovulate on? Okay, if we increase the length of the cycle, it is going to be the pre-ovulatory phase which lengthens. She will have a conception, I should say ovulation, which occurs 14 plus 7, which is 21 days. She ovulated on day 21, which would be January 21. Okay, the exposure of the radiation was February 1. So she ovulated, probably conceived on January 21. How many weeks post-conception was the exposure to the barium enema? In the second week. What's the impact going to be? It's either going to be intact survival or it will be death. Now, when we look at the radiation dose, 4 rads, what is the threshold at which we see significant impact? It's going to be 10, 5 to 10 rads. So for 2 reasons, we can feel quite comfortable with this fetus. Number 1 is the exposure occurred in week 2, and the second is that the radiation dose was pretty minimal. She was not using any contraception. A urine pregnancy test was positive on March 15, which is what you'd expect. What is the risk to her fetus of teratogenic injury? And the answer is basically minimal, if any. So she can be reassured. Okay, let's look at various agents that result in teratogenesis or adverse outcomes. The radiation dose, if you look at exposure, which is less than 5 rads, there is basically no significant risk. Even up to 10 rads, the risk is minimal. When we're looking at significant dose of exposure, we're looking at 10 rads or more. And when you look at almost all of the diagnostic modalities that we use, whether it be a chest X-ray, whether it be a abdominal CT, whether it be a IVP, even barium enemas usually will not go over 10 rads. So when a woman has been exposed early in the pregnancy to radiation, what is the likelihood that she should be advised to terminate the pregnancy because of teratogenesis? Almost never. Almost never. It's amazing the resistance and resilience of the embryo and of the fetus to chemotherapy. Let's say that she develops leukemia in the first trimester or in the second trimester. What is the risk? The fetal risk from chemotherapy is highest in the first trimester, which was what you'd expect, but even then it is only 20%. In the second and third trimester, the risk is about 5%, which is no different from the general population. So the primary risk is in the first trimester. Obviously, we'd rather not use it any time in the pregnancy, but it's primarily in the first trimester. It is gestational age dependent. Now let's look at some specific prescription drug syndromes. First, I just want you to notice on this, actually this is an advertisement from Pfizer, and it looks at the lips, and the reason is because you're supposed to love the diflucan, which is fluconazole. But I want you to notice what is called Cupid's bow here. You see this Cupid's bow? That, and here again is the Cupid's bow. You don't see that in children who have fetal alcohol syndrome. They have a loss of Cupid's bow, and they also have a long philtrum. Now this is the philtrum right here, from the bottom of the nose to the top of the lip. You see on this one child here, a long philtrum, and you have the absence of Cupid's bow. Smooth philtrum. Now here's a child who has a nice Cupid's bow. You see this Cupid's bow right over here? Isn't this a beautiful child? Well, of course. This is my grandchild. And here she is a few years later. There's a lot of other stigmata of fetal alcohol syndrome, which we don't need to go into. In your notes, you'll notice that there are, in the italics, the most common findings that we will see with the various syndromes. I might say that fetal alcohol syndrome is one of the most common preventable causes of mental retardation in children. DES, what does DES stand for? Diethylstilbestrol. Diethylstilbestrol is a non-steroidal estrogen which used to be used in years past to try to prevent pregnancy loss when there was bleeding in the first trimester. Now, what is the most common cause of first trimester loss? We know it's aneuploidy, abnormal chromosomes. What can you do to change that? Basically nothing. And yet this is what we used. What are the impacts in a teratogenic way of diacylstilbestrol? Here we have a normal-shaped triangular uterine cavity. With a DES-exposed uterus, what do you see? A T-shaped uterus. That would be worth remembering for the boards. Another finding, which is probably more serious, is increased risk of clear cell carcinoma. There's also adenosis, which is columnar epithelium, on the exocervix and on the vagina. The Müllerian anomalies, which you see with DES, are significant enough that the American Fertility Society has given a separate category for DES-related Müllerian anomalies. Here we have a hysterosalpingogram of a normal uterus, and you notice the triangular shape. Here we have a DES uterus, a T-shaped uterus. And unfortunately, many of these women will have early deliveries of babies, or even have failure for conception to occur. This is an advertisement from an OBGYN journal about 50 years ago. And it's quite remarkable in how it is promoting the use of DES. This is what it says. It's hard to read. 96% live delivery with DES plex in one series of 1,200 patients. Bigger and stronger babies too. What's the message? You want to have a strong, big baby? Why, take DES. Can you believe this? This was in 1957. And now we realize this was crazy. We should never have done this. And it makes me think, as we move on in our understanding in years to come, looking back now, we will probably say, that was so stupid. Let me give you another example of this. These are some advertisements that were in the media decades ago. 20,000 physicians say Luckies are less irritating. What's the message? Why, your doctor smokes, so you should smoke. And now we know very clearly that 1/3 of people who smoke will die from that. Okay, dilantin phenytoin. Notice the face of this child here. Craniofacial dysmorphism is found in the dilantin teratogenesis. Notice these babies, our children, are unrelated, and that they have the same pixie-shaped nose here. Craniofacial dysmorphism. This would be an important one for the board exam. Not that this causes any significant impact in function, but notice the tiny, small nails. Fingernail hypoplasia is seen with dilantin phenytoin syndrome. Isotretinoin. What is the trade name for isotretinoin? Accutane. Accutane. This is used by what age patients? Typically, it's going to be used by teenage female patients. And some of the concerns that we have with isotretinoin is small ears, microtia. You can see how small this ear is. What is this right here, do you think? This is a cochlear implant because there is eighth nerve problems also with isotretinoin. Now this is talking about systemic. This is oral, not the topical. There are also, this also shows the ear malformations which can occur. Unfortunately, it's not just the ear. There are all kinds of other malformations, particularly of the heart. And the FDA, Food and Drug Administration, is very concerned about this and bringing about some major restrictions on the use of Accutane. If a patient wants to use Accutane, they have to pledge that they are going to follow certain guidelines or they will not be prescribed it. They have to use simultaneously 2 forms of contraception. They have to have 2 negative pregnancy tests. One must be in a laboratory, so not just home pregnancy test. They have to go online to answer questions on their reproductive life. They are given only 1 month's supply of medications, and they have to certify that they are using 2 methods of contraception, and before they can get a second supply for the next month, they have to have a negative beta HCG. This is a major concern, Accutane birth defects. Now, of course, if you have a baby that develops Accutane problems, what do you do? What is the American way? The American way is sue. So you sue the company, you sue the doctor. And this is the license plate of an attorney who lives down my road. I sue for you. Isn't that sweet? Accutane must not be used by female patients who are or who may become pregnant because of severe birth defects. Okay, another teratogen is lithium. What is lithium associated with? Epstein anomaly. Here's Epstein anomaly. This is a normal right atrium and right ventricle. This is the tricuspid valve. It is downward displacement of the tricuspid valve leading to a large left atrium. Epstein's anomaly associated with lithium. Here we have tetracycline. What does tetracycline do? Deciduous teeth discoloration. Now, your friendly dentist will be more than happy to whiten your teeth. This is not a major anomaly, but it's one that could be very well on the board exam, so you should know it. It is really where you have the calcium is being displaced by the tetracycline. And here you can see the tooth discoloration also. So we don't use tetracycline during pregnancy. Here is a good board question. Thalidomide. What does thalidomide cause? Phocomelia, limb reduction. And you can see the short extremities here. And on this cartoon character here, we have short extremities on both the upper and lower limbs. Thalidomide used to be used for nausea and vomiting in pregnancy, and it was very effective. Very effective. It was used widely in Europe, but it was not allowed in the United States, and that was fortunate. The interesting thing about thalidomide was that the teratogenic effect was only between day 42 and 48. There was a narrow window of time, and if the exposure occurred either before or after, there'll be no impact. It's an excellent drug, but during these critical periods of time, it led to major risks. Now, thalidomide has been reintroduced into the United States for use to treat leprosy and multiple myeloma. A lot of discussion by the FDA before they allowed it to be used because concerned that it might get into the hands of pregnant women. Here you can see on this image a very short proximal extremity here. And here you can see phocomelia also. Valproic acid, the trade name is Depakote. This is associated with neural tube defects. And interestingly, it's more likely going to be a spina bifida than it is to be anencephaly. It's also associated with congenital heart disease. And here you can see this neural tube defect right there. Valproic acid is used by many women and has been linked with birth defects, and probably more problematic than many of the other newer anti-epileptic drugs. For instance, lamotrigine, Lamictal, is probably much safer than valproic acid. And so doctors are urging women not to use valproic acid if they are in the fertile years. This is of concern to me. Depakote, or valproic acid, is used to treat bipolar disorder. It is used to treat migraines. And I wonder how many of these women who are taking this realize the impact potentially if they should become pregnant. Coumadin is an anticoagulant. It is taken orally. It has a small molecule. It can cross the placenta, and it can cause lots of birth defects, optic atrophy. It can cause problems with hemorrhage, but one which is a good board question would be chondrodysplasia punctata. And you can see here the calcification at the costochondral junction on this infant. this X-ray here. All right, that's the end of our embryology and fetology section.